Welcome to the University of California, San Francisco Sports Medicine Podcast, featuring Dr. Nira Fundia, Dr. Brian Feeley, and Dr. Drew Lansdowne, discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
Hi, welcome to this week's 6 to 8 weeks. I wanted to do something a little bit different this week and go over one of the most common things that patients ask. What happens when I have a rotator cuff tear? Now, this is one of my favorite topics. My other favorite topics include football, especially the 49ers and random trivia for the 49ers, surfing in Northern California, dinosaurs, and anything science. I'm happy to cover those in other podcasts, but I think covering the natural history with rotator cuff tears and what happens to patients when they have a rotator cuff tear is probably of interest to more people. So I think this is a fascinating topic for a variety of different reasons. Most importantly, this is extremely common, and we often see this progression over time. So patients tend to have a partial thickness tear. We sometimes will see other patients with full thickness tears, and the decision-making in terms of what we do for each patient depends on activities and goals for the patient, size of the tear, how much it's bothering them, what treatments they've had in the past. And I think this allows us to have a really nice shared decision-making process with the patients. That being said, there's a lot of information out there. And I think what my goal for this is to really kind of synthesize this information in about a 20 to 25-minute lecture to help patients figure out what's going on with a rotator cuff tear, what their treatment options are, and what's best for them, and kind of understand a little bit of the science behind it. So without much further ado, let's get into it. So when I think about rotator cuff disease, I think about it in kind of a spectrum of different problems. You have impingement or inflammation above the rotator cuff, all the way to massive unrepairable tears that are going to need some sort of reconstruction. So I really like analogies and everyday references to pathology in order to represent what's going on. And I think many of us in sports medicine and orthopedic surgery have heard the analogy or use the analogy of a tire wearing out for arthritis, where you lose more and more of the tread. So this is my roof analogy for rotator cuff tears. Impingement, which isn't the best named term, but implies some inflammation above the rotator cuff, is kind of like having leaves on the roof. You probably won't even need treatment. Sometimes these leaves will just blow off, and that would be analogous to taking some anti-inflammatories, maybe doing some physical therapy. But we can do a surgery where we go in and clean up the inflammation, kind of like getting on top of the roof and brushing those leaves off, but leaving the structure of the roof intact. Now, partial tears, which we'll hear are extremely common, come in two flavors. There are tears on the bursal or top side of the rotator cuff. This is like when you have some shingles off the top of the roof. It's probably okay, not really a big tear, but you may want to keep an eye on it, especially with winter coming. Similarly, on the undersurface, you can have articular-sided tears, and these are like having a little crack in the ceiling. It's not a big deal. It can be sort of a cosmetic thing, but you want to keep an eye on it. So a small full-thickness tear can be a bigger deal, and I think this is a lot of the confusion when patients are diagnosed with a full-thickness tear. Most of the rotator cuff, or in this case, most of the roof, is still intact. But there is a small hole where essentially if you're sitting in your living room or your bedroom, you can look up and see the sky. This is also why location is important. You can imagine if you have this hole you've got a big bedroom in the small corner of the room, doesn't really matter necessarily. It probably does, but versus if this is right over your bed and anytime it drizzles, you're getting wet. So the location of these tears are really important. And this is a good example of a tear that is right above the biceps tendon that disrupts the front part of the rotator cuff cable, and that ends up causing an increased amount of pain and biomechanical problems, as well as some early muscle degeneration. And finally, there's massive tears, and that's when the whole roof is blown off. You may want to try and repair the roof, but you're probably better off just replacing or reconstructing the whole thing. That's when we consider doing a shoulder replacement for these tears. So how common are rotator cuff tears? And this has been demonstrated in a few different ways, but the study I really like was done by Dr. Yamamoto and his colleagues in rural Japan. He took all comers in a village, examined 1,366 shoulders, and found that overall 20% of all shoulders had some sort of tear, either partial or full thickness, and 50% of people over the age of 60 had a rotator cuff tear. So that's half the patients over the age of 60 in this village had some sort of rotator cuff problem. He then followed up that study with another one a year later and found that in 285 patients with a cuff tear, 2/3 of them were actually fine and didn't have any symptoms. So from these studies, we can conclude that rotator cuff tears are common, they increase with age, but they often don't cause symptoms. Now, what about US studies? Ken Yamaguchi, who is a great clinical researcher and built an outstanding team at WashU in St. Louis, did a series of nice studies where people came in with a rotator cuff tear on one side, and their group enrolled them to follow them not only on the symptomatic side, but also on the asymptomatic side. So if you have a cuff tear on one side and have symptoms, 40% of those patients will also have a cuff tear on the other side. And over 5 years, about half of these tears will progress. Most of these patients will have tear progression, meaning that their tears will get bigger when they become symptomatic. So when a patient has a tear on one side, so if you have a left-sided tear, and then you start having symptoms on the right side, I have a lower threshold for looking carefully at the symptoms on that other side. So that begs the question, who is actually at risk for these rotator cuff tears? So I think one important factor is genetics. And these are some really nice studies done by Bob Tashin and his team out of Utah, where they looked at the genome-wide associations, or GWASs. There is a GWAS study group in Britain, and there's another one in the Kaiser Medical Group in the United States. And this allows you to look at the entire genome and differences in people with or without a condition. Now, what they found was that there were a few genes that are associated with having a rotator cuff tear, as well as some genes that seem to have differential expression, meaning they're either upregulated or downregulated. And these may suggest a control for these. So in the United Kingdom database, they found 3 novel gene locations that are associated with having a rotator cuff tear. And one of those genes, the aptly named THSD7A, was also downregulated in terms of protein expression, suggesting that this actually may be a protein that has some sort of role in developing symptomatic tears. So genetic factors are important, but they're not actually modifiable. The genes you have, for better or for worse, are kind of the genes you have. Now, what about other factors to a certain extent that we can control? There was a really nice study out of Korea in 2018 that looked at a group of both symptomatic and asymptomatic people. So patients that had a rotator cuff tear on MRI, either partial tear or full thickness tear, but may or may not have had symptoms. Now, they found that there were a variety of different independent risk factors, and this is important because there are factors that depend on each other. So what they found was that being older gives you an increased risk, which we already knew. Dominant side involvement was a slight increase in having a risk factor for a rotator cuff problem. Having done manual labor, at least in this study, was a big difference. So you may have a much higher incidence of having a rotator cuff tear if you did manual versus desk labor. Having metabolic syndrome, I think, is important because that's a combination of diabetes, hypertension, hyperlipidemia that is what is relatively modifiable. So being healthier overall seems to lower your risk factor. Now, what about symptomatic tears? And Nitin Jain and his group, who run a large database of patients with rotator cuff tears in the United States, found similar but not entirely the same findings. They found that getting older, being male, and having a higher BMI were all independent risk factors. And interestingly, they found that smoking was not associated with the presence of rotator cuff tears. So smoking is not a risk factor for developing a tear. For those people that smoke, it is a risk factor on whether or not that tear will heal when we do surgery. When we look a little bit closer at this data, it had about 260 patients, so 266 patients. 163 of these patients had a rotator cuff tear, and they were compared to 103 patients that didn't have a rotator cuff tear. Now, what was interesting in terms of symptomatic tears is they did find that symptomatic tears were more likely to be on the dominant side, and heavy use at work was also associated with a higher risk of a symptomatic tear, which kind of makes sense. Was what was not shown is whether or not patients who had higher recreational activities, like they swim more, they did more upper body sports, whether or not that's actually been associated. And no studies, at least that I've found, have it shown that this is a independent risk factor, kind of your recreational activities. So there's probably something to do with genetics, some are habits, some just getting older, all of which puts us at some risk for developing rotator cuff tears, especially over the age of 65. But what happens once you do have a rotator cuff tear? So when do people go from being asymptomatic to symptomatic? We know a lot of the patient population have rotator cuff tears. They're just not symptomatic. Well, if we look back at the studies from Yamaguchi's group, we find that patients end up developing pain when the size of the tear gets bigger. So when people are having tear progression, that's when they tend to get pain, which is really important. This isn't necessarily a silent thing where your tear is getting bigger and bigger and bigger. You probably know because your shoulders starting to feel different. Now, Dr. Stefan Moosmeyer has done a lot of really interesting studies, and we'll get back to one of his most important ones later, did another really nice study where he looked at 50 patients with asymptomatic full thickness tears and followed them over 3 years. So very similar to the Ken Yamaguchi study, found that 18 out of 50, so about 40% of patients developed symptoms over that time. And over those 3 years, the tears that got bigger, so on average more than a centimeter compared to less than 5 millimeters, were the ones that were more likely to develop symptoms. And about a third of those patients did develop some change in your overall muscle quality. This has been backed up by a variety of other studies. This was done by Dr. Yamamoto, who found that, again, risk factors for progression, age greater than 60, fatty infiltration on MRI, and a larger tear. So the way I like to think about these risk factors is that they all kind of come together, especially as we get older. So older age is going to lead to a little bit more risk of progression. As the muscle starts to degenerate, you're going to get more progression, more symptoms. And as the tear gets bigger, that's going to kind of auto stimulate the tear to get bigger and bigger. So it can be a very, very slow process for years on end. And then it can kind of accelerate at the end, kind of like those gravity pits that you see the ball accelerating down towards a black hole. So what happens if you don't fix a rotator cuff tear? Now, I think this is really important because a lot of patients just don't want surgery. And honestly, most patients don't need surgery. So this is one of the classic studies that I really like. This is done by the Moon Shoulder Group. It won the coveted NEAR Award almost a decade ago now, and they did what's called the cohort study. This is a really nice study because it's really practical. Patients came into clinic and they basically said, would you like surgery? No. Okay, well, we'd like to enroll you in a study where we're just going to see how you do with non-operative management. Non-operative management was physical therapy, some discussion of rest, activity modification as fit the patient, anti-inflammatories, and sometimes an injection. And they found a variety of really important things. First of all, they found that the size of the tear was not an independent risk factor of whether or not this was going to be successful. They found that the biggest predictor of whether or not you got better with physical therapy is whether or not you felt physical therapy was going to be beneficial. They also found that people who did well early and their shoulder function improved in the first 6 weeks of physical therapy got better, and most of them stayed better. So that's really important when you talk to patients who start physical therapy. It's not like something you have to go on and do 2 years of physical therapy for. You know you will be doing better within those first 6 weeks. And those outcomes have been really durable. When we look over time, those patients that have done well in the first 2 years when this study was published, most of those results have held up. So certainly those patients that do well with physical therapy may have a sustained benefit. So in terms of how I use this clinically, I think it's okay to try non-operative management, especially if a patient wants it to work. You can also cross over if you're not happy. I often tell patients the worst that happens is you get a physical therapist you like, you find a time within those first 6 months to decide when to get this fixed. It doesn't have to be an emergency, and it tends to be successful in most patients. Now, what happens if you don't fix this right away? Because oftentimes life gets in the way. You've got a promotion at work, you're retiring and you want to travel, you've got weddings to go to. And Albert Lin and his group in Pittsburgh did a really nice study where they divided patients into two groups: patients that were fixed and had rotator cuff surgery within a year, and those were fixed greater than a year out. And what they found was that there was no difference in re-tear rates, whether or not there was a successful repair or patient-reported outcomes. So the patients felt the same whether or not they had surgery right away or delayed. And I think that's really important when you talk to patients, especially when they're deciding, can I get it fixed in 6 months when it's convenient, or do I need this done right away and really alter my life? And the straight answer is you don't need to get it right away for atraumatic tears. Now, when we think about, again, that gravity pit of when things start to accelerate, that's years down the line. And this was a nice study, again, by the Ken Yamaguchi group and Jay Keener and Aaron Chamberlain out of WashU. And what they found was that asymptomatic tears take years to enlarge, sometimes up to 4 years, and then another year or so before we see any muscle degeneration. So you can get this fixed way, way, way down the line. It's just going to be something that you want to keep an eye on. So what I do for my patients that I feel like, gosh, you don't really feel like you need surgery. You are symptomatic. It is bothering you, but this isn't the right time. I'll often repeat that MRI or in some cases ultrasound to look for tear progression about a year afterwards. If you're not progressing, I don't really do anything about it other than just say, come back in another year. If you are progressing, that may change the conversation a little bit and say, well, if you're starting to have muscle changes, maybe we should think about intervening. So what happens if you fix a rotator cuff tear, and what is our rationale to actually fix these? Well, again, looking back at Nitin Jain, he did a really nice propensity score analysis. So this is a nice way to compare patients between groups at shorter time points. And what they found was that for younger, meaning under the age of 60, higher demand patients, patients that use their shoulders more, and especially patients who were not happy after physical therapy, there were better outcomes short term with surgical fixation. So in some patients, it might be the better treatment strategy, especially for your higher demand patients. Now, again, this goes back to Stefan Moosmeyer's second set of studies, and this is a great set of studies. So they looked at 2 years, 5 years, and 10 years of a 10-year study where they randomized patients to either physical therapy or surgery. And when we look at that data, when you look back at that 2-year study, there was no difference between outcomes. So it looked like at 2 years, you randomized people, great, both groups are doing really, really well. When you look at 5 years, the patients that had rotator cuff tear repair were doing really well. Their ASES score was above 90. That's an excellent score. There was a little tiny bit of a drop in physical therapy, but it didn't look clinically significant. But then at 10 years, there's another about 7 to 8 point drop. And now you have about a 10% difference in how patients are doing at 10 years with surgery versus physical therapy. So in your higher demand patients, patients that really feel like there's a long event horizon, they want to use their shoulder for 10, 15 years, I think it's really important to at least consider rotator cuff repair in these patients. So in terms of physical therapy is done for about 3 to 6 months after a rotator cuff repair. And I think this is important to think about, like, why we go so slow. And the reason is multiple studies show that if you're going to re-tear, it's going to happen early, especially in 3 to 4 months after surgery. So this has been shown by this group, by Bruce Miller's group out of Michigan, as well as other studies that have shown that re-tears happen early. But then when you get further and further out, the patients that heal tend to do very well. Now, one of the things that you can do now is you can use Peter Chalmers' data to look and see what the likelihood of re-tear rate is. And I really like this in clinic. And so if you're in clinic or you're at home and you type in Peter Chalmers, MD, and you type in his re-tear likelihood calculator, and you can put in different risk factors. So you can put in 72-year-old male, doesn't have osteoporosis, not too high work activity level, and you can put in the tear size, whether it's partial or full thickness, and muscle quality, and it'll tell you the likelihood that the patient will have a re-tear. And I think this is really nice in terms of patient counseling. So I wanted to go through how we do a rotator cuff repair, and this is shortened into about a 3 to 4 minute video. This is looking top down. So you're on top of your roof and you're looking down. We're removing those leaves. That's the bursa. So now that the leaves are removed, we can really see the roof, and we can see that there's a small full thickness tear. So you can see this hole here where we clean up the footprint or on the bone where that rotator cuff needs to be attached. So that's us just cleaning up the bone, and we want a nice bleeding surface. And then we put an anchor in, and an anchor is either in this case, a bald piece of suture that gets put into the bone, or it can be a piece of plastic that's usually inert and doesn't dissolve, or in rare cases, it can be a piece of metal. There are sutures that come off that anchor, and those are going to allow us to pass that through the rotator cuff. And there's a variety of different suture passing devices. I like to pass an antegrade suture passer, which allows me what I think is a little bit more control, but they all work about the same. They allow us to target exactly where we want those sutures to be. And for these small tears, how we fix them doesn't really seem to make a difference in terms of success rates. It's just a question of getting a good watertight seal and then reestablishing that footprint. So here we are passing the sutures, and we pass them one at a time. And I like to pass from front to back. There really isn't too much of a difference. It's just how I trained. And I think it makes it a little bit easier in terms of suture management. For these small tears, I think like I said, any tear configuration or repair configuration is going to work. We usually want about a centimeter or a little bit less between these sutures. That way the repair will come over and kind of sit down nice and evenly. If you're too close together, it tends to bunch up. If you're too far apart, it tends to dog ear, where you get a little bit too much extra tissue in between. Once those are passed, we can bring those sutures through the lateral portal. Each of these anchors usually has either 2 to 3 sets, but I like to pull the sutures over and confirm that this looks like when I tie this down, it's going to really cover that footprint. And this looks really good, but I'm already starting to think, well, it'd be nice to back that up and really restore that whole footprint. So then we use arthroscopic knot tires, and that allows us, in most cases, to kind of really push the tendon down. There are some knotless configurations. I tend not to like those as much for the rotator cuff. I really like to see that indent and feel like I'm really pushing the rotator cuff right down to that freshly cleaned off bone. Now we can use a second row or a transosseous equivalent, which allows us to pull the sutures over in a lateral row. I think it backs up the sutures. It creates more of a contact area, so allows the rotator cuff to really sit down and restore that contact area. And other than a few extra minutes in the OR, I really don't see the downside in many of these cases. So once we finish the rotator cuff repair, I like to look at it, move the rotator cuff back and forth, make sure there's no holes. This is looking from the side, so we're looking straight down onto the roof, and we really can't see into your house anymore. We can't see the shoulder, and we can see that footprint is really nicely restored. So in summary, rotator cuff tears are very common as we get older. People who are at risk for rotator cuff tears, males seem to be a little bit more common than women. There is a genetic component. People who are laborers use their shoulders more throughout their lifetime all day, tends to be a bigger risk factor. Dominant side seems to be more of a risk factor for symptomatic tears, which kind of makes sense. And some of your general health risk factors, having a higher BMI, having diabetes, having higher hypertension, are going to increase the likelihood of having a rotator cuff tear. Once you have a rotator cuff tear, not everyone will get symptoms, but the people who get symptoms are probably the ones having tear progression. We should take those patients seriously. Now, if you don't fix a tear, that's probably okay. For some people, physical therapy is fine. They will continue to be fine for an extended period of time. But for others, those symptomatic patients, the ones that are feeling worse, there may be a slow increase in tear extension and progression, and eventually muscle degeneration. Now, if you fix a rotator cuff tear, healing in those first 6 months is critical. But once you pass that stage, you're likely to be okay. So that 6 months of recovery is critically important. But then for the vast majority of patients, you can go back and do absolutely pretty much whatever you want. So thank you very much. If you have questions, people are welcome to contact me. And hopefully this is helpful and can help people understand a little bit more about rotator cuff tears.